What's going on, everybody? There's nobody in the room right now, so I'm talking to an empty room. Today I'm talking about clinical nutrition, the role of the clinical dietitian in the hospital, and I'm just going to wait a few moments for a couple people to get in here. So right now we just have 2 viewers, but for those of you who are watching this after the fact, I hope you stick around for at least a couple minutes to hear about clinical nutrition. And then we're going to be talking about some artificial nutrition sources that I'm using on an everyday basis. So it should be a good one. I'm just going to give 1 more minute since it is just 10 o'clock right now. But if nobody's here in the next 30 seconds, I'm just going to start talking. In the meantime, I'll drink this cup of coffee. What's up, Coffee the Beagle? I have a dog viewing. That just made my day. If I have a dog watching me do this, then that's good. And my mom just joined. So now we're up to 3 total people. So I'm going to go ahead and get started. My name is Mitchell Zandes. I'm a registered dietitian here in the United States. And if you're watching this right now, it's the morning on Sunday in the United States. And if you're elsewhere, it could be Monday, so you're getting the week started already. But I'm out here in New York City. I'm a clinical dietitian, so I work in the hospital. And I wanted to come on today just to talk a little bit about clinical nutrition, because oftentimes when I tell people what I do, they don't quite understand what it is. So a clinical dietitian, in my role, is not doing what typical nutritionists would do, or at least the public perception of what a nutritionist is doing. Usually people think you're in an office where somebody comes in and gets general nutrition counseling about how to improve their diet, how to manage diseases, or improve their lifestyle overall. That may be a small part of my role, but basically I'm in the hospital working at bedside with patients who are admitted. So there are a couple different fundamental roles I have there. One of them is making sure that people are receiving the right diet prescription while they're getting food in the hospital. So different diseases need to be managed with different nutrients. For example, somebody with congestive heart failure, while they're admitted, usually is going to require a restriction of sodium and also of something like fluid. Because those nutrients in excess can exacerbate the symptoms of their CHF. Another example would be somebody with diabetes. Whether somebody is admitted to the hospital with complications of diabetes or for any other reason, if they're sick, they're usually going to need extra careful attention to their blood sugar control. So one of the roles of the nutritionist in the hospital is to make sure that we're providing them with food that'll give them the best chance of keeping their blood sugar under control. So diet is one. And then obviously doing diet education for when they leave the hospital. And this is where it would be more of the traditional nutrition counseling that people are aware of. So for example, using that CHF patient or a diabetic patient, really getting into the nitty-gritty of what's been going on with them at home and why they may be having the problems they're having managing their disease. And a lot of disease management starts at that root of nutrition therapy, which is one of the reasons why I'm so passionate about what I do. And I always talk to my diabetes patients or a CHF patient or a chronic kidney disease patient about their medicine, right? The doctors can give them whatever medicine they want, whether that's insulin therapy, they could be on dialysis, and that will help to manage some of their symptoms. But if they're not attacking that root cause by controlling what they're eating, they're not truly reaping the full benefits of that medication. And that's hard for people to understand. We live in a society, obviously, where people are always looking for those quick fixes. Oh, somebody just said, "Shut up, you bitch." What's up, Dara? Thank you very much. I appreciate you. I wish you the best. So Anyway, we live in a society where everybody wants a quick fix. So somebody gets diagnosed with diabetes or CHF and they think the medication is going to solve everything for them. I try to make them realize that they need to fix other areas in their life as well. So we have making sure people are on the correct diet. We have diet education. And that's probably the toughest part for us as dietitians in the hospital. People are sick, right? They're not feeling well. They're admitted to the hospital. Sometimes the last thing they want is for somebody to come in and start talking about nutrition. When they're not really interested in food at the time, if they're not feeling well, and they just have, a ton of different people coming into their room and talking to them throughout the day. So I feel like diet education is one of those areas in my role that is very important, but is not really gets the true effect. If people want to learn about what they're going to do when they leave the hospital, they're best seeking it while they're healthy and outside the hospital. And really, it comes from the inside out. So you can't force diet education on someone. Like somebody who's chronically not adherent to their medications or their diet, you can't really go into a room and tell them what to do and expect them to do it. There needs to be that self-realization and, that they need to seek it out if they really want to make the changes. And I oftentimes think that doctors don't really see that, and they'll ask us to go talk to patients and educate patients who aren't really ready to receive diet education. Either they're too sick and they're not in condition to really process the information, or they're just chronically not adherent. And not to say that it's not worth it anymore, but it's just not the right time for us to be visiting them and trying to talk about nutrition education and making them change their ways. So getting the right diet education. And the last one, which is really going to continue on for the rest of my conversation today, is nutrition support. So a lot of people when they come to the hospital are able to eat, but there's that whole other subsection or patient population of people who can't eat. And so we know that nutrition is very important to healing, but it's also very important to immunity. So, to maintain health, preserve health, but even in small amounts just to protect the person from further infection, further decline. So it's important that when somebody is sick, and even very sick, that they be in an intensive care unit, that we're taking care of them in a way that we can just give them the minimal amount of nutrition to stimulate that immunity. So, for example, I guess what I'm talking about here is nutrition support is tube feedings, right? So when we're putting tubes down people and giving them artificial nutrition, that's one way. And then also intravenous nutrition. So these are for people who can't feed themselves, they can't eat, and so we're giving it to them artificially. I guess that's where that conversation starts in a very roundabout way. So the first one, tube feeding, this is going to be for somebody maybe that has head and neck cancer, they can no longer swallow. Somebody who has very advanced dementia, same thing. They're not eating, they can't swallow, and so we're going to have to give them nutrition through an alternate route. Another one would be people who are critically ill and admitted to an intensive care unit. They're going to be on a ventilator, obviously, and then at that point we're sticking tubes down them to feed them. And like I said before, the goal is not always to feed them to make sure they're meeting all of their calorie needs. Sometimes if it's somebody that's critically ill and they're admitted into the intensive care unit, we're just giving them a very, very small amount of nutrition. And that may be 1 to 3 ounces per hour. And the reason for that is not to make sure that we're meeting their nutrient needs, but it's really just to stimulate that gastrointestinal tract. And what that does is that it keeps the gastrointestinal tract, the muscles of it, active, and also stimulates that gut microflora or the gut microbiome, which we know plays a critical role in immunity and a host of other different things. So it's important for anybody who can't feed themselves to at least get the minimal amount we can. So if we have somebody who the gastrointestinal tract is working, is not blocked in any way, we have 2 ways that we can get a tube down into them to start feeding them. The first one is going to be through the nose or the mouth. And basically what will happen is a doctor will come in, they'll lubricate a tube. The tube goes right up their nose. The patient has to swallow if they can, and they push it down and feed it down into the stomach. At that point, they need to get a chest x-ray to make sure that the tube has gone into their stomach and not into their lungs, which would be very undesirable. And once that is confirmed, then we can proceed with feeding the patient. So the food that we're giving them is not taking regular food and blending it up. It's commercially processed food, formulated to have all of the carbohydrates, proteins, fats, vitamins, and minerals that you need to survive. So basically they come in these bags. It looks like a yellow or white milky substance, and it hangs in the room. And then my role as the dietitian is to determine how many calories the person needs and in what ratio they should get their carbohydrates, protein, depending on the situation. And then based off those numbers, I'm determining how fast we're going to feed them, so the rate at which they're going to get their food. So it's very simple in the fact that we're just taking food, pushing it down their nose, directly into their stomach, and everything's taken care of. But there are a lot of different factors that go into it. Now, I don't know where I'm going with this now. So certain things that we need to take into account, right, is the situation of the patient. What is most important at this point? So if somebody is like a burn patient that has lots completely burned in a fire or something, they're going to need very high protein needs. Do you have to cancel family members of patients? Yes, absolutely. Definitely counseling family members of patients who are there. One of the biggest parts of there would be patients who have dementia. So a lot of elderly people start losing their cognitive function, and the family members or a health aide is the one taking care of them at home. So usually in that situation, you play an integral role in counseling the family to teach them how to take care of these patients. And those patients in particular, ones with cognitive decline, are the ones that don't want to eat. So they'll just go all day. And they don't feel hungry, they're not starving, but they just won't eat or drink anything. So it's important to educate the family that they need to constantly encourage the person to eat throughout the day. And then also we know that what your dietary habits and what you're eating is a product of the environment you're in. And so if you have somebody with uncontrolled diabetes or a special dialysis diet for chronic kidney disease, you need to make sure that the wife, the kid, anyone who is in their immediate environment is on board and recognizes that this person has unique dietary needs and that they need to support them in that effort. Because if somebody with diabetes is living in a household where there's cake, candies, sweets constantly around them, and it's provided by the wife or the husband or whoever it may be, they need to realize that they're setting them up for failure in managing their disease and not really pointing them in the right direction. So yeah, it's important to counsel family members and make sure everybody's on the same page. Can you explain the relation between diet and mental health? I can in a very brief manner. The relation between diet and mental health, I mean, definitely there is a connection there. You eat good, you take care of yourself, you start to feel good. There is also, emerging research on the gut microbiome and mental health, things like depression, anxiety. So just making sure that your gut is in check there, you're feeding it the right things, which would be whole grains, legumes, nice fibrous foods, cutting back on refined sugars, probably red meats as well. That's Mom, thank you. Yeah, that was a shout out. Diet, relation between diet and mental health, it's definitely a connection there. That goes with physical activity as well. But it's kind of hard to formulate into a quick response there, other than there definitely is a connection between how you take care of yourself, your mental health, and your physical health. So if your mental health is not in check, it usually manifests itself physically as well in other derangements throughout the body. So those are the questions we have so far. So going back to the artificial nutrition support, so when people have the ability to use their gastrointestinal tract, we're feeding them with artificial tube feedings through the nose or mouth, and that's if it's going to be short-term in the hospital. If we think that they're going to need a tube feeding for longer than, say, 3 weeks, then we may recommend that they're going to get a gastrostomy. And what this is a surgical procedure where they're getting a feeding port put into their stomach, and that way we can get rid of that tube in their nose or mouth. So we call them PEGs. It's percutaneous endoscopic gastrostomy. Basically, they just feed something through the nose, and then they pop it out through the stomach, and then they can pull the thing throughout the nose. So they have this little port, and then they can just be fed, whatever they need to. They can either be continuous, which would be fed round the clock throughout the day, or they can get a bolus regimen, which is where we're just feeding them, maybe every 6 hours, every 4 hours, whatever is best tolerated by the patient. If it's somebody who is cognitively there and is active and going around, then we're going to try to set it up in a manner that they can continue, with a semi-normal or normal life or lifestyle. So we may set them up with a breakfast, lunch, and dinner type style if they can handle it. So those are the two ways, nose or mouth, or directly through the stomach there, that we're going to feed somebody with tube feedings. And it's definitely a fun part of my job to be doing those and calculating the unique needs and teaching patients how to feed themselves if they're going to be going home with it. What can be considered as a balanced diet? The balanced diet I want to get to, do paraplegic patients also get a lifelong gastrostomy? So if they're paraplegic, good questions. Those are very good questions, Raisa G. Thank you. Paraplegic, well, if they typically no. Like a paraplegic will usually have function of their upper extremities, and they will be able to eat by mouth. There may be unique cases in a quadriplegic where they're not able to eat as well, and they'll lose function of maybe their esophagus, or they'll have really poor motility, and we would have to give them a tube feed. I don't really see that many quadriplegics or paraplegics, but it certainly is possible. And another thing, it may not be 100%, so somebody with quadriplegia may be able to eat in some capacity, but they can't eat enough to maintain their weight. In that way, we could give them a gastrostomy and maybe provide 50% of their calorie and protein needs through the gastrostomy, and then we'll just supplement the rest with mouth. We'll just give them some of their favorite foods, maybe some smoothies, high-calorie smoothies, and make sure they're getting enough. And that really promotes quality of life. So it's not easy to be fed through the stomach all the time. So if somebody is able to eat by mouth, we're going to do that as much as we can. Yes, the gastrostomy procedure is reversible. So a good example of this would be somebody who has head or neck cancer. They may be undergoing radiation therapy for several months at a time, and during that time they're not able to swallow. So they will have a gastrostomy, and when they're not able to eat for those several periods, several months or maybe even years, they'll use that gastrostomy, and then once they're in remission and they're doing a little bit better, maybe they'll start eating by mouth. and they can either just keep that gastrostomy or they can get rid of it altogether. And they do take the gastrostomies out sometimes. But oftentimes, if it's somebody like a cancer patient, it might be a good idea to leave it. There is a risk of infection if it's just sitting there and not being used. But if it's well taken care of at home, then it shouldn't be too much of an issue. Those are interesting questions. I like those ones. So yeah, the other one was about the balanced diet. Basically a balanced diet is, being able to maintain your health while also eating the foods that you love, right? So you can live a very healthful life, enjoyable life, eating every food there is out there, whether that's pizza, fried chicken. It's all about making sure you're doing the right things most of the time. But I would say a balanced diet has variety, right? There is variety in your food choices. You're not eating the same things every day. You're eating a wide range of different fruits and vegetables. You're eating mostly whole grains. And just making sure you're doing the right things most of the time, and then finding a way to maintain your quality of life by having maybe those foods that we would consider bad in a sense. So going back to the nutrition support, those things are if somebody's having functional gastrointestinal tract, but that's not always the case. So somebody could have bowel surgery, right? They could have stomach cancer. They could have cancer of the small intestine, pancreatic cancer. What's the ratio between healthy and diet? I'll get to that one in a second. But sometimes the gastrointestinal tract can't be used in cases like cancer, or maybe a small bowel obstruction, whether that is just like from ulcerative colitis, Crohn's disease. Sometimes that small bowel or large bowel can get really tight up or closed completely, at which point, the person can't eat anymore because then they're just continuing to push things down a tight hole. It can get blocked. And if you continue doing that, eventually it can perforate and be life-threatening. So there are certain situations where people are unable to eat, and I deal with this a lot in the hospital, as I have been covering a surgery unit for some time now. So if somebody is unable to eat and we can't give them a tube feeding, we can do intravenous nutrition. This is called parenteral nutrition. And there's two different ones. So there's peripheral parenteral nutrition, and that's where we're just running it through a typical IV. Or we could do total parenteral nutrition, and that's when we're running it through a central access line. So that is those are usually deep lines here or up here in the chest area that pretty much go directly to the heart and then shoot out to the rest of the body. And you can give somebody full nutrition this way. It's definitely not the preferred source. For one reason, you're not stimulating that gut the same way you would be with the enteral nutrition, which we know is very important. But also there's a higher risk for infection, right? You're pushing a whole bunch of nutrients into an active site in your body, especially bacteria likes to feed on sugar. So when we're pushing a whole bunch of sugar in somebody, intravenously, there is a higher risk for infection. There's also long-term complications to using parenteral nutrition, particularly in the liver. So when this first came out, I think it was in the 80s, it was the hot new thing, and everybody thought it was going to completely change the game, and it did in a sense, but I've been told that if you went into a hospital in the 80s or early 90s, pretty much anybody is going to be on parenteral nutrition because they thought it was the saving grace. But what they found is that long-term, you're going to get serious issues with the liver. And that's basically just because you're pumping all the nutrients directly into the bloodstream instead of going through the complex process of digestion, absorption, and metabolism. So there are, we're not going to want to keep somebody on long-term parenteral nutrition unless we have to. But in the short term, it is definitely helpful to them, and that's been shown in research. So decreased length of stay, decreased mortality, and so it's pretty interesting stuff. And I will say, doctors, as educated they are and as amazing things they do, nutrition is one area that most of them don't have a good foundation in. And so when it comes to this nutrition support, which is a vital part of patient care, it's really not something they're well versed in. They're not able, or they don't have the time to sit down and really figure out what they need to be giving the patient. So it's nice to have a dietitian on staff who can handle all of that for them. Particularly with parenteral nutrition, I find that doctors simply have no idea what they're doing with parenteral nutrition. And when they do order it, they can put in orders that are pretty dangerous for the patient. For instance, somebody with diabetes shouldn't be getting a high sugar load to start out. That can be very dangerous. And so sometimes I've seen doctors put in orders where they're giving upwards of 400 grams of carbohydrate to a diabetic patient, where they really should be starting around 150. So it's nice to have a dietitian there in the hospital keeping an eye on those that are going to get parenteral nutrition and making sure that mistakes like that are not happening. So I want to answer this question: what's the relationship between healthy diet and exercise? Well, healthy diet and exercise go hand in hand, right? You need the proper nutrients to fuel exercise, and if you want to get the full benefits of exercise, you're going to need the healthy diet. I guess that made sense in a way. But for exercise, right, we need the proper macronutrients, so we need the proper calories, proteins, carbohydrates, fats, but we also need the proper micronutrients as well, right? We need to make sure we have the vitamins and minerals that are helping to fuel our body in the correct manner. So there is a strong relationship there. And in terms of body composition, right, a lot of times when people are thinking about healthy diet and exercise, they're thinking about ways that maybe they can lose weight, build muscle, get into better shape. We all know the old saying, you can't out-train a bad diet. So the relationship between healthy diet and exercise there is you could be in the gym and do a very, very thorough job exercising, but if your diet is not in line with your goals, then you are not putting yourself in the best position to succeed. So for instance, you may have a young man who is trying to put on significant muscle mass, and he's going in the gym, he's doing all the right exercises, he's bench pressing, he's squatting, he's deadlifting, but outside the gym, he's not eating enough calories, right? He's below his calorie needs. He's not focusing on protein to promote muscle synthesis. This person is not going to get that muscle gain they're looking for, because in order to gain muscle, you're going to need to be in that calorie surplus, so you're going to actually need to be eating more calories than you need, and you're really going to need to focus on making sure you're getting enough protein to fuel that muscle synthesis. So that's just one example. Another one would be somebody on the opposite end of the spectrum that may be trying to lose weight. So they could be doing their weight training exercises, they could be doing aerobic activities, but then they're going out and they're eating fast food or high calorie foods often. If they're not in that calorie deficit, they're not going to be losing weight, no matter what's going on. What's going on, Mr. B? Yeah, so there's definitely a strong relationship between diet and exercise, and it goes both ways. So I think, it's always important to take care of both instead of just focusing on one. So I guess I can circle back to that nutrition support again, since I don't have any questions here. So any thoughts on long-term effects of a ketogenic diet on healthy individuals? That's another good question. I'm happy that you're here, Erasa G, because I'm kind of lost in my nutrition support discussion here. I didn't prepare quite as well as I should have. So long-term effects of the ketogenic diet, that's one of the missing pieces of the ketogenic diet right now. So we don't really know what's going to happen to somebody if they're doing it for 10, 15 years, especially in a healthy individual. I would say with the way the diet is set up, there may be concerns with cardiovascular health or things that we haven't quite seen yet. Because with the ketogenic diet, you are really switching your physiology. So currently, myself and probably anybody who's watching this right now, their body is being fueled primarily by glucose, particularly their brain. A ketogenic diet would be switching that fuel source to ketone bodies, which are made from fat instead of carbohydrate. So it's really just a complete switch on how your body is being fueled. And it's truly a built-in survival mechanism that we have. So the reason ketosis exists is for times when we're not able to have access to carbohydrate, and eventually we're going to have to fall back on fat as a fuel source instead of feasting on our muscle protein. So people who are on a ketogenic diet and in ketosis, essentially what they're doing is they're intentionally inducing and maintaining the survival state of ketosis. It's very fascinating. I don't like to take a hard line on ketogenic diets, whether they're good or bad. I don't think they're sustainable for most people, but people do have success on them. People do well with diabetes. There are some athletes who do well with ketogenic diets. Weight loss, there's definitely success stories out there that are not phony. They're real, measurable results, and their blood work is good. And so when you see these things, it's kind of difficult to deny that the ketogenic diet is working for some people. It's not something I'm going to be recommending any of my colleagues, friends, clients to do, but if somebody is interested in doing it and truly believes in it, I'm confident I have the knowledge to kind of lead them in the right direction to how to do it. Thank you, Addictive Photographer. I'm happy to be here as well. This is fun. So long-term effects of ketogenic diet. I think one of the long-term effects that is particularly harmful is non-adherence to the dietary regimen. So ketogenic diet is something that you need to be pretty strict on all the time. And if you slip up, then you may be coming in and out of ketosis, which is not going to be very desirable, because the way the diet is set up with the very high fat content, if you're not in ketosis and using that fat for fuel, then you're basically just a normal general population person running on glucose eating a very high fat diet. And we know from decades of research that that is not a desirable thing. Now, a ketogenic diet is going to be upwards of probably 75 to 80% fat. And so if you can imagine what that would look like in somebody who's not in ketosis, it's not a very healthful diet. So I'm happy to see that we have 6 people here right now. Please keep some questions coming. That way I can kind of just keep on answering questions instead of going back to my nutrition support discussion, which has been pretty broken up. If you're just joining, we talked about enteral nutrition, so tube feedings, whether through the nose or mouth or through the stomach. And then we talked a little bit about parenteral nutrition, which is through the veins, intravenously. And as a clinical dietitian, it's my role to make sure people are getting the right formula for these 2 interventions, and make sure that they're kept in line. So with the parenteral nutrition, more so than the other forms of nutrition, you're going to have to be monitoring blood laboratory values, things like sodium, potassium, magnesium, phosphorus. Those are all things that are in the formulation that we're injecting into their veins. And so we need to make sure that we're not giving them too much, not giving them too little, and we're adjusting that pretty much on a daily basis. So somebody who is on parenteral nutrition or just starting, we're watching them very closely every morning. They're getting new blood values drawn, and we're adjusting their formulation to make sure we're not giving them too much. Now, I would say potassium is the nutrient that we are most concerned about, because if somebody's blood potassium goes up high, which can happen rather quickly, it can stop their heart and they can die. Now, the potassium doesn't always go up just because we're giving them too much. Things in the blood like potassium, sodium, phosphorus, and magnesium can change for a whole number of different reasons. But we can always cut back on what we're doing if it's going up for other reasons. Same issues can present if we're giving them too little. So if somebody's potassium goes low, that can also be very detrimental. So we need to make sure that we're infusing enough. Those are things that are being checked every day. Another one, the most common side effect of parenteral nutrition would be hyperglycemia, because we are, when you eat a meal, right, say I'm eating a lot of carbohydrates like a peanut butter sandwich, there's other components that are slowing down the digestion, such as fiber. The combination of nutrients delays the absorption, and so we're getting a little bit of a slower glycemic response. When we're injecting it into the vein, there's not quite as many stops along the way, and so people who are on parenteral nutrition, even if they don't have diabetes, they are prone to hyperglycemia, which is not good for a lot of different things. Oh, Heidi Farouk Khan sent a request to be in the video. Can diet alter the efficacy? How? Okay. Can diet alter the efficacy of drugs that patients may be on? Absolutely. Absolutely. I think in terms of altering, right, you're thinking of decreasing the effectiveness of the drugs, but one thing diet can certainly do is undesirably increase the efficacy of the drugs. And an example of that would be a whole bunch of medications interfere with grapefruit. Grapefruit, I think, blocks the breakdown of the medications, and so they continue to circulate without metabolizing the way they should. So there are certain medications out there. I think a lot of blood pressure medications, or statins. Yeah, statins for blood lipids. There's certain statins where people should avoid grapefruit. Another one would be warfarin, right? So warfarin or Coumadin is a blood thinner, and we have vitamin K in our diet. Vitamin K is a nutrient that helps to clot the blood. So we have two different effects here. We have the medication that's trying to thin it, and vitamin K that is trying to clot it. So somebody who is on that drug certainly needs nutrition recommendations. When they come from the doctor, it's usually avoid all vitamin K and let the Coumadin do its job. But vitamin K is found mostly in dark leafy green vegetables. It's not really a good idea for somebody to cut those out of their diet altogether because of the multiple benefits they bring. So somebody who is on this blood thinner, the current recommendation is that they try to keep the amount consistent on a week-to-week basis. So that way, the doctors can adjust their medication dose around what they're eating. For instance, somebody who enjoys spinach, kale, broccoli, if they're eating a cup of that a day, every day of the week, they want to make sure that they do that week to week. So they don't have 1 week where they're eating vitamin K foods every day, and then another week when they're not eating any at all. If they do that, there could be issues with the blood getting too thin, the blood clotting up, which is probably why they're on the medication in the first place, which could certainly be an issue. So yes, medications and nutrition, statins, warfarin, medications can also impact that potassium I was talking about with intravenous nutrition. There are certain medications that preserve potassium and can make the potassium go up in the blood, so it's important to look out for those. Question from Patty OZ. How much should I reduce my daily calories if I am unable to exercise at all due to injuries to hips and back? It's all about food choices, Patty OZ. I think a good place to start would be to documenting what you eat throughout the day, keeping a diary, and then really taking a look at what you're eating, how much you're eating, and where that measures up to your daily requirement for calories. So if you are interested in learning how to calculate your calorie requirement, or you want me to do it for you, you can certainly reach out. I'm happy to do it quickly for you. And then you should just keep, a 3 to 5 day diary. We can see where you measure up, and we can also identify maybe areas that you can cut back on calories. That's a definitely important thing. If you're not able to exercise, you're not able to move, that's probably a time where you need to be extra careful with what you're eating, because you're not going to be burning as many calories. So good questions from both Patty OZ and Raisa. Raisa, I hope I'm saying that correctly. Yeah, so good questions. Since I don't have any, let's see, what time is it? It's 11:40. I'll probably go for another 15 minutes here. So, in addition to keeping control of the potassium, phosphorus, magnesium, sodium, obviously we're going to be looking at their blood sugar control. If we have to, we're giving insulin inside the parenteral nutrition. If not, they're going to be giving it on the outside subcutaneously, or they're going to be doing both. That's something that certainly needs to be taken into account. I guess the final component of that would be fluid. So we're making sure that our fluid that we're giving them is matching how much they're putting out. So we don't want to be giving too much, we don't want to be giving too little. We want to make sure we're kind of hitting it right on the head with how much fluid they're getting, and trying to make it so that the doctors don't need to give any extra fluids, they don't need to give any electrolytes outside. Oh my God, Ali Bayer just joined the chat. What up, Ali? Ali, ask me a question about clinical nutrition. I need you. Shit, what was I saying there? Oh, I got distracted. Ali, ask me a question so I can stop talking about the stuff I'm talking about. Okay, she just woke up. So I was talking about fluid. So making sure that we're giving them the right amount so they're getting kind of a balance between what's going in and what's going out. And this can change pretty rapidly. All right, I think I'm starting to come to an end of what I wanted to talk about. Just kind of a different side of nutrition that people aren't normally thinking about with enteral and parenteral nutrition. Kind of gives a different perspective on what can be done with a nutrition degree and as a registered dietitian. So there's very different avenues that people can take. This is just one of them that I find very interesting. Gives us an opportunity to be there on the sideline with doctors, really get to take part in patient care, participate in a hospital, and try to move people in the right direction. Right? Being sick is not fun. People are in a very vulnerable position, and so it's nice to be able to be at bedside and try to help them out and move them along the way. It's also a nice opportunity to work as part of a team. I know, there's definitely dietitians who are solo practitioners who are just seeing patients, doing their counseling, and not necessarily able to participate in a team environment. So it's nice to have different practitioners that you can talk to, learn from them, give your 2 cents, take recommendations from them, and just be part of a team environment. And it's also fun to have people that you work with, especially when they join your live video. I got Adrienne and Allie here, 2 other clinical dietitians. So thank you for joining. Yeah, so that's it for me. I can't really think of anything else. So if anybody has any questions, I'm going to give you about 30 seconds to give to, I'm happy to keep talking. So if you give me another question, I'll keep on going. Otherwise, I'm just going to wind this down because it's been going on for a while. All right. Well, I thank you, everybody who joined and took the time to listen to me talk today. I'm not sure how well organized it was or what I actually said or didn't say, but I tried my best. It's not easy to get onto one of these live videos, especially without good preparation and you just start talking. So that is going to be it for me. Thank you guys so much for joining. Thank you to the Addictive Brain for having me on here and supporting my work. They do an incredible thing by bringing different scientists from all over the world together, sharing their passions, sharing information, and they're very inclusive for different disciplines. So thank you so much to them, and I continue to work with them, continue to look forward to working with them in the future. I hope everybody enjoys the rest of their day. Have a good one.